This is a lecture on antifungal drugs. The, as you will see from this lecture, that we don't have that many antifungal drugs relative to the number of antibacterial agents that we have, for example. And the reason for that is there are several reasons for that. One of them is the fact that fungal infections in general were not as prevalent as bacterial infections. They were mostly infections, opportunistic infections in immunocompromised people in general. However, over time, as you will know, the prevalence of immunocompromised individuals has increased due to many reasons, one of them being the use of drugs. The other are diseases, immunodeficiency diseases, particularly AIDS, and others. Another reason why it has been difficult to develop antifungal drugs is the fact that here we're dealing with organisms that are eukaryotes as opposed to prokaryotes. So these are cells that are similar to our mammalian cells, and therefore it is more difficult to find targets that confer selectivity to the drugs. Nevertheless, there are differences, and as you will see, the drugs that we have available will target specific components of the fungal cell and are able to achieve some degree of selectivity. Now, the classes of antifungal agents are few. There are two major classes, the polyene antibiotics and the azoles. And the azoles are divided into two subclasses, the older imidazoles and the newer trizoles. And then we have another class relatively recently discovered, the echinocandins, which are, however, limited in spectrum. We have antimetabolites like 5-fluorocytosine, which is also very limited in its use. And then we have individual drugs that we will mention, like griseofulvin and other topical agents. Very briefly, this slide represents the targets of the various classes of drugs. Uh, amphotericin B, which is the main, most important drug in this class of agents, targets the cell membrane of the fungi by binding to a specific component of it, um, ergosterol, which is the sterol in the fungi, as opposed to cholesterol, which is in our cells. The azoles also target ergosterol, but in a different manner. They inhibit the synthesis of ergosterol. So again, targeting the cell membrane and affecting membrane permeability and the activity of enzymes in the membrane. Uh, the echinocandins target the synthesis of the cell wall, and therefore the cell loses its osmotic integrity. The nucleic acid analog 5-flucytosine, or sorry, the pyrimidine analog 5-fluorocytosine targets cell DNA synthesis, and a number of others also, uh, like naphthene and terbinafine, target also ergosterol synthesis, though at a different enzymatic step than the ergosterol synthesis targeted by the azoles. So let's talk about the polyenes first. Amphotericin B. This is the, if you want, the most effective among the antifungals. It's a fungicidal agent, which is an advantage, particularly in immunocompromised individuals. Its name derives from its structure. It's a polyene, which means it has multiple double bonds, carbon double bonds. As you can see in this picture, which depicts the molecule is elongated, rod-like, with one side containing these methylene groups, the lower part, and the upper part containing the hydroxyl substituents of the carbon atoms. Now, it is this structure specifically, it is thought, that explains the mechanism of action of amphotericin B. As we said, this is the drug of choice for most systemic invasive fungal infections. Uh, Even when there are other drugs that are effective, like the azoles, if the infection is rapidly progressive or severe, or is in immunocompromised individuals, we prefer to use amphotericin B if the patient can tolerate it. And you will see it has some toxicities later on. So, as I said, the structure of amphotericin B is what confers its mechanism of action. Here is a slide that illustrates this mechanism of action. Basically, what it says is that the molecule of amphotericin B interacts with the cell membrane. Specifically, it acts as a pseudo-phospholipid and places itself in the membrane in such a way that the methylene side of it, the double bond side, interacts with the sterol in the cell membrane the same way that the phospholipid interacts with the sterol, the hydrophobic ends of the sterol. And it therefore, if you consider this a three-dimensional structure, what will end up is multiple molecules of amphotericin B placing themselves in the cell membrane with an inside that is the hydroxyl groups pointing all towards the inside together, and the other end of the molecule, the polyene, the double bond, within the membrane, thus creating what appears to be a pore in the membrane, an aqueous pore, which is where the hydroxyl side of the molecule is pointing. Uh, so the molecule dissolves in lipid, but also is water soluble. That's allowing the aqueous pore to form. This therefore does away with the selective permeability of the cell, and as a result, things start leaking out. Molecules, potassium first, but then others, and then cell death ensues. Now, why the selective toxicity to fungal cells and not to mammalian cells? Well, the reason is the type of sterol that is found in the membranes. So, in the human cell membrane, we have cholesterol, which is, as you can see depicted on the right side, it's a sort of an S-shaped or a bent molecule, whereas ergosterol is a straight molecule, as you can see. And so the chances of amphotericin B interacting with ergosterol are higher, or the energy needed to interact is less than with cholesterol. It's not favored with cholesterol, and therefore the reaction is favored with ergosterol. So, at a certain concentration of amphotericin B, you will find that there will be a predominance of pores formed in the fungal cell as opposed to the mammalian cell. Of course, amphotericin B does interact with cholesterol, but not with the same ease and with the same facility and affinity, if you wish, as it does with ergosterol. Now, the binding to cholesterol in human cells is probably at the basis of some of the toxicities that we will discuss later on. What do we use amphotericin for, amphotericin B? Well, as I said, it's the drug of choice for many systemic fungal infections, including all of these that are mentioned here, aspergillosis, blastomycosis, etc. The nice thing about it is that very little resistance is reported. If there is resistance, if the organism develops resistance to amphotericin B, many times it has been reported that this organism also loses its virulence, its pathogenicity. So resistance is not a problem really with amphotericin B. And as I said, especially important for immunocompromised individuals and AIDS patients. We can also use it for prophylaxis against fungal infections or in patients who have fever and neutropenia. That is, the people who are, for example, take chemotherapy and they suffer neutropenia and then develop fever. You suspect that this fever may be due to an infection, but you don't know the source of the infection. So you need to treat these people with drugs. You use antibacterials, but also use antifungals. Amphotericin B can be one of them. The adverse effects to amphotericin B can be divided into two types. Those that are acute or that are related to the infusion. Now, amphotericin B can only be given intravenously. If you give it orally, it's not well absorbed and it's not given intramuscularly. So, intravenously, there is an infusion that has to be given, and sometimes adverse effects happen like chills, acute reactions, fever, dyspnea, even bronchospasm, sometimes in severe cases with hypotension and convulsions. Now, these things happen more common initially, but then they wane with time. Uh, and so it is recommended actually to start with low doses of amphotericin B, and then build up the dose gradually to prevent the severity of these infections. Not infections, reactions. Uh, they are managed with easily with either non-steroidal anti-inflammatory drugs or with steroids. Also, antihistamines can help if you are if they develop certain reactions like bronchospasm. The more important, so these are effects that can be managed easily and that can be prevented largely if you start with low doses and build up and with other drugs. But the more limiting toxicities that we encounter uh, are below the chronic toxicity, and predominantly it's nephrotoxicity that is limiting. And what I mean by limiting is that sometimes when it happens, it necessitates that you stop the drug for a period of time so that renal function comes back to normal. Anemia does develop, probably due to a decrease in erythropoietin levels, but it is not a severe anemia and can be tolerated usually by the patient. So, what about nephrotoxicity? What happens? Well, we know that this nephrotoxicity it happens after chronic administration with a decrease in GFR, a rise in BUN and creatinine, indicating decreased filtration function of the kidney. But it also involves tubular dysfunction, like the function of the tubules to concentrate the urine. The kidney can no longer concentrate urine, can no longer get rid of acids easily, so impaired urinary acidification. And very commonly, people suffer from potassium deficiency and hypokalemia. Also, they may lose magnesium and hypomagnesemia. But hypokalemia is almost an invariable consequence of the treatment with amphotericin B chronically. It's important when you treat with amphotericin B to be careful and be aware of any other drugs that are also nephrotoxic because you could have additive nephrotoxicity. Among the such drugs are, for example, you've studied the aminoglycosides can be nephrotoxic. Um, so these are the kinds of reactions that you have. The most, of course, serious among these is the decrease in the filtration function of the kidney. The main function of the kidney is filtration of the plasma. If you get decrease in renal function, then you have either to decrease the dose of amphotericin B or decrease the or stop it for a while. What is the mechanism? The mechanism, we know, for example, that when you give amphotericin B, even acutely with the infusion of amphotericin B, you get a very severe vasoconstriction in the renal arteriolar bed with a consequent decrease in GFR. So renal blood flow decreases and GFR decreases. And when you stop the infusion, these effects are ameliorated. They are reversible quickly. Now remember the structure of the kidney and the unit of the kidney of filtration, which is the nephron. As you know, the nephron consists of the glomerulus, which is the tuft of capillaries that is coming out of the renal arteriole on the left, surrounded by Bowman's capsule, the capsule where filtration takes place. This is the filtering surface. and then a series of tubules, the proximal convoluted tubule, the Henle's loop, this down-up configuration, and then the distal tubule, and then the collecting duct. And the urine flows through this meshwork of tubules and eventually ends up in the ureter. These tubules can secrete and also can reabsorb substances and water. And on the right is the actual filtering surface where the fluid going through the capillaries is filtered, and the driving force for the filtration, as you know from Starling's forces, are the hydrostatic pressure in the capillaries, the plasma hydrostatic pressure, minus the plasma oncotic pressure, right? The oncotic pressure in the plasma keeps fluid in, the hydrostatic pressure in the plasma drives it out. And countering this filtration is the hydrostatic pressure in the tubules. Now, when we studied uh, the effects of amphotericin B on glomerular mesangial cells, these are cells in the glomerulus surrounding the capillaries, which are contractile cells. So these cells, when they contract, what do? They contract around the capillaries and they obliterate them such that the blood can no longer flow through the capillaries. So what would result from this in terms of filtration? Of course, you're going to interfere with the filtration and you're going to cause a decrease in glomerular filtration rate of the kidney. So here is an experiment that we did. I did some research on amphotericin B, and I'd like to share it with you to see how the nephrotoxicity happens. When you add amphotericin B to cultured mesangial cells and measure intracellular free calcium levels, what you see is this brisk rise in intracellular calcium levels. When you have a rise in calcium, free calcium, in a contractile cell, what does that mean? It means the cell is going to contract. So amphotericin B, placing it on the mesangial cell in culture, causes it to contract. And you can actually see it under the microscope contracting. Now, interestingly, this effect on the right can be modulated, can be prevented by a number of interventions. The first intervention is if you remove calcium, the small column, the next small column next to the uh, control. Notice that if you remove extracellular calcium, you don't see this rise in intracellular calcium. What does this tell you? It tells you that the source of the calcium is the extracellular fluid. It's not coming from internal stores, it's entering from outside. Next, if you remove sodium from the extracellular fluid surrounding this cell, the next column, and replace it with another osmotically active molecule to maintain tonicity. So if you remove sodium, what happens? Again, you prevent the rise in intracellular calcium. This is intriguing. But then if you add a drug called diltiazem is a voltage-dependent calcium channel inhibitor, right? It inhibits voltage-dependent calcium channels. If you add that drug, it also prevents the rise in intracellular calcium you observe with amphotericin B. So these three results are quite interesting. What do they suggest? They suggest a mechanism of action. Let's see what if you can answer on this next slide. What do you conclude about the mechanism of contraction of mesangial cells by amphotericin B? There is depolarization and release of intracellular calcium. There is hyperpolarization and release of intracellular calcium. There is depolarization and entry of extracellular calcium. There is hyperpolarization and entry of extracellular calcium. I think you should interpret the experiment and come up with the result that this is actually depolarization and entry of extracellular calcium. Why? Because